everyone. My name is Kashif Shaikh. I'm a third year cardiology fellow at Creighton University, Nebraska, Omaha. Today, we are very privileged to have Dr. Omar Khalique with us. Dr. Khalique is an assistant professor at Columbia University. He is the director of multimodality imaging. He's also the co-director of Advanced Structural Imaging Fellowship. Thank you so much, Dr. Khalique, for joining us.
Pleasure to be here.
So this is interview for FSCCT 2021, focused towards more early career and fellows. We just would like to know about your journey, how you got interested in structural heart imaging, if you would share with us.
Sure. So I think it was absolutely no planning at all and mostly luck. Although people think I planned the whole thing out. So basically what happened was I did my cardiology fellowship between the years of 2008 and 2011. I knew I was interested in imaging. In my program at the time, New York Medical College, we only had access to echo mainly. So then I entered the advanced echo fellowship at Columbia in 2011. And by chance, that was the same year that there was the first FDA approval for TAVR. And I had done some valvular research in general fellowship, and I kind of just fell into it, doing the cases from the start and learning about everything from the ground level. My philosophy was always to do what I was interested in. So at Columbia, there was a wider array of modalities available. So I learned cardiac CT with Andrew Einstein, and then went on to learn cardiac MRI as well with John Weinsaft at our sister institution, Cornell. And my focus was always structural. So the nice thing was being there from the starting point of when we were doing 20 TAVRs a year to the volume exploding, and nowadays it's between 500 and 600 a year. So it's been quite a journey and a real area where the heart team was developed and multimodality imaging was integrated into the field of structural heart.
Amazing. That's been a great journey for sure, and we have been watching it. So this structural heart imaging interventional physician, we have been hearing this term more and more. Could you educate our audience about this term?
So I think it's a very important term, and what used to happen and what still happens sometimes is that the structural interventionists who are doing the procedure, kind of refer to the imaging as a modality, so the CT or the echo. But what it really is a physician who's equally involved in making the decisions for the case. And as you and many of the FSCCT members know, it's in some procedures, it's mainly the imager making most of the decisions. So it's the imaging physician who's a cardiologist and sometimes an anesthesiologist in the cases, guiding the MitraClip, really instructing the interventional team on where to position the device. The strategy for implantation is discussed as a team. And then in terms of other procedures like TAVR and TMVR, it's imaging is a huge part and the main part of the pre-planning for the procedure. So whoever your imaging expert is, whether a cardiologist or a radiologist, that structural heart imaging physician is deeply ingrained and involved into making decisions for the case. So I think was one thing we need to step away from is referring to the person as a modality when actually they're an integral member of the team.
Right, makes sense. So what do you think are some of the career challenges for structural heart imagers?
Yeah, so we've written on this extensively, and there are a number of working groups and committees now devoted to these subjects of both multimodality imaging in general and specifically structural heart imaging, which is a large area which incorporates multiple modalities. So I think some of the challenges are common to a multimodality imager who doesn't focus on structural, and those would be poor reimbursement for reading studies, especially as a cardiologist who may just be receiving the reading fees and that small amount of money not being really recognized or supported by your department, whereas the technical fees may go to the radiology department, and that's 90% of the income. The time that it takes, which is not really reimbursed, to do complex procedural planning and virtual implantations, the time it takes to go into cases and do a long procedure, for example, mitral clips and now tricuspid clips, which are evolving well in the clinical trials. So that time to reimbursement issue is very common and being recognized as a member of the team, which really drives these procedures, which are income generating. And I think an additional challenge, which is a general challenge, is very pertinent to the fellows, so the first committee, and that is, people are interested in imaging, and as I said, I always went with what I was interested in. I didn't always have a perfect plan of what I was going to do with it, especially early on in the structural game. But let's say now there are a few programs like Houston Methodist, Brigham, Cleveland Clinic, which will train people in 3 or 4 modalities to get level 3. But then when you go into practice, what is the feasibility of using all of that? So that's a major challenge, being well trained, and even going to a center where you could be reading or participating, and then being blocked by political issues, by these reimbursement issues. So those are the challenges which, 10 years later, people at my stage are still dealing with, and hopefully trying to make headway for your generation, that things will improve for the future.
Right. So you mentioned about multimodality imaging. Now it's July, there are a lot of new fellows coming in, and they ask about the career in multimodality imaging or advanced imaging fellowship. And there is so much diversity in those training programs. What would you tell them? What advice would you give them when they're looking at career in imaging?
Yeah, so that's a very important and pertinent question. And I have a whole slide set devoted to that when I give talks. But as you said, it's so there. I have a slide which shows all of the ACGME accredited fellowships in cardiology, and it's basically every single one except for imaging. So you have your heart failure, you have your interventional, you have now congenital. So they have electrophysiology. So that creates more uniformity in the training because it's a requirement. And as you said, with the imaging fellowships, which now there's a very nice database in the ACC where you can look at all the programs by state and what they all do. In my day, we had to manually search for all of those, so it was very tough. So that's a good thing the ACC has done, which is also being furthered by the societies like FSCCT. But you really, it's tough, I think, for a fellow coming out now. So it a little bit depends on your interest, which it may be hard to develop. I think every imaging fellow at this point is being expected to come out and do some structural. So the main components there are echo and CT. CMR is a little tougher. So I was trained and read CMR because I like it. I think it's cool. I'm interested in it. But in structural, it plays an increasing role, but less so. So the ideal scenario is that you train in everything and you read everything, but I think you have to focus on a disease state maybe that you're interested in rather than a modality. So, I'm interested in structural, so these are the modalities I want to learn. Maybe somebody's interested in cardio-oncology, maybe somebody's more interested in coronary disease. So they focus on those, CT and CMR maybe. So there's different pathways you can go, and it's a little bit of finding your own path as you go along.
Right, that's a great advice. So, Dr. Khalique, you have been leading the way for pre-procedural CT evaluation for tricuspid valve interventions. Could you talk about what has CT taught us and how CT is valuable in addition to TE and MRI when it comes to right heart or tricuspid valve pathologies?
Yeah, so in the structural space, I think we really learned about the increasing role of CT. When you get to the tricuspid regurgitation population, at least the one that's in trials now, CMR becomes a bit tougher. Many of the patients are older, they can't lay down for a long time, they have AFib. So those are various issues for CMR, and also many of those who have TRs from pacemakers. So that's another challenge for CMR. CT is very fast. It gives us a full volumetric data set. Now with advanced scanners, AFib and arrhythmias are much less of an issue. So you can acquire the whole heart in one heartbeat with a volumetric scanner, or very quickly with a dual source scanner, or both potentially. So there's a very high temporal and spatial resolution. The devices like pacemakers are actually, they have a little bit of artifact, but they're well seen, and you can really judge the relationship to the leaflets, for example, and the annulus. And you can get a pretty good functional assessment. So getting your RV volumes, your RA size, and obviously a lot of the virtual planning that we do for the procedures. TE is obviously critical, and echo, TT, and TE for the quantification of TR, especially in patients where we do face those challenges with CMR, as I mentioned. So I think CT will play an increasing role. The other simple thing that's good about CT is that, besides imaging physicians, I think, the images are typically very clear and understandable for, interventional cardiologists, for surgeons. So I think it's a modality which reaches out further than echo, which is a very powerful modality, of course, but I think is less clear to the untrained eye than some of the nice CT images we get nowadays.
Right. So for the structural heart imaging training, they have, like you had mentioned earlier about, there are no set goals. There was a document from Jack Imaging, I think you were part of it, about core competencies in structural imaging training. And I think it was more focused towards TAVR. It suggested maybe perform 25 to 50 cases, be part of like heart team, 10 of those cases. What do you think the direction would be in future, and could some of those early career cardiologists assimilate if they want to do more of the structural heart imaging? What would your advice be to them if they are not particularly trained in imaging fellowship?
Yeah, so there were two documents that were sister documents. One was CT and one was on echo. But they're really closely intertwined, of course. I think, nowadays it's hard to just do one. They're really both go hand in hand for structural. I think increasingly in general fellowships, people are getting some training, but some of the challenges we discuss in that document are getting the numbers that you need for each procedure. TAVR is pretty common, but for example, left atrial appendage occlusion is still ramping up in some places. Some are using a lot of TE, some are using more CT for the pre-planning. TMVR, the only approved procedure is valve and valve, but there are others evolving. So getting all those numbers is a challenge. So we proposed in there potentially having some online training, visiting fellowships, those types of things. The other challenge, as you mentioned, is if you didn't get the training in your fellowship, doing it as an early career. So that would be another area to have a visiting fellowship, online education, but it becomes tough. So I think the most important thing to learn in a fellowship for structural imaging is learning to learn, because you need to learn how to learn about every new device, because there's always going to be another one. So it's really the framework of how you look at a device, not just an imaging scan. So when we train our fellows, we advocate, you need to know quite a bit about the procedure itself. You need to know what is the French size, what does the device look like pre-cramped after deployment, how does the catheter move, what are some of the wires even that are used, what is the stiffness. So it's really a cross-training modality fellowship, and that's apart from just the imaging. So, and every time we get a new device, so you get device A, and then device B, and then device C comes along, and a new procedure or a new iteration of devices, like there's Sapien, then XT, S3, then there's going to be S4, right? We need to learn how to then just incorporate that new device into the framework of what we've already learned. So, we know how to measure the aortic annulus, but what is the new sizing algorithm? Are there any differences? Is the device any longer? Is there a different skirt? Is the catheter different? So that's the most important framework to learn, because learning that from scratch each time is probably not the right way to do it. So I think it's a different kind of learning than I think we've encountered in the past, just because the field moves so quickly. Even I was trained 10 years ago, but I have to learn about 2 to 4 different new devices every year. So that becomes challenging if you've never learned how to learn in this space.
Right. Well, thank you so much, Dr. Khalique. Those are all great insights. I'm sure our fellows at FSCCT would appreciate all the great advices. Thank you.
You're welcome.